I'm going to discuss on new horizons in andrology. Are we heading towards super subspecialization? Now, I just want to give an analogy of reproductive medicine, which is an established subspecialty of OBGYN. Now, we are aware that RM subspecialty training is for a minimum of 1.5 to 2 years and covers various clinical and research aspects. You have male infertility covered, early pregnancy, endocrinology, genetics, reproductive biology, reproductive surgery, ultrasound imaging, psychology, and counseling. The whole objective of the reproductive medicine program was to improve knowledge, practice, teaching, research, and audit. Additionally, coordinating capabilities and promoting collaboration and organization of a comprehensive service, providing leadership in development and research within the subspecialty. We know that management of subfertile couples involves a comprehensive assessment as well as use of assisted reproductive technology and requires a multidisciplinary approach, and it requires the subspecialist to be trained in areas of endocrinology, andrology, reproductive medicine, reproductive biology, genetics, psychology, and early pregnancy complications. Gynecologists surprisingly embraced multidisciplinary training approach for comprehensive management 2 decades ago, and patient needs dictated evolution of the RM subspecialty. Now, when we compare that to andrology training in a urology residency, where several surveys have been done, 65% of European and 35% of American urology residents reported feeling uncomfortable in a new consultation evaluating infertile patient and interpreting even a semen analysis. More than half the responders said they would not go to their own training institutions seeking male fertility care if they ever had a problem or their relatives had a problem. Only 18% of hospitals offered formal microsurgical training for urology residents in USA and Europe. Many of them, only 50% of them had an operating microscope, and only about 65% in US and 34% in Europe had used an operating microscope. So essentially, American and European residents shared the same frustration regarding their education and exposure to andrology and male infertility during residency training. For any residency training, we need good faculty who is exposed to the branch. And when we look at the surveys which have been done on the impact of having male infertility trained faculty, we find a similar picture where 72% of respondents reported male infertility comprised less than 10% of the training, and only about half of them had faculty who were trained to an extent in reproductive urology or andrology. Residents exposed to infertility faculty were likely to rate their training in infertility to be either moderate or good, but those residents who are not exposed to would not rate or be highly confident managing fertility cases in their outpatients. So infertility comprises a minority of residency training. Most residents anticipate performing infertility procedures in practice despite 2/3 lacking confidence performing this. So the net summary is having an infertility faculty and formal microsurgical training improves residents' surgical confidence of managing both male infertility as well as azoospermia, non-obstructive azoospermia, and global male infertility understanding. Now, when you look at urology residency and a career choice, because nowadays it's an era of subspecialty, residents get a fair exposure to endourology, uro-oncology, female urology, reconstructive urology during their residency. However, the same did not hold true for pediatric urology, andrology, laparoscopic or robotic urology. 90% of the residents expressed an inclination towards academic practice, while 76% were interested in subspecialty. When you look at how many were inclined to andrology, less than 20% were inclined only towards female urology, andrology, or pediatric urology. So only 1/5 of them were inclined because of lack of exposure during their residency. What happens when you are not exposed to a proper andrological subspecialty training? We are all trained in a urology residency program or an MCH to evaluate male infertility on the basis of medical history, physical examination, and we do have a decent diagnostic workup. So, and this is what is the algorithm we follow in terms of infertility basic diagnosis. The idea of this basic evaluation is to understand the pathogenesis, which we know could be either genetic, hormonal, immunological factors, psychological factors, lifestyle, and then plan, or because of earlier surgical interventions, infectious diseases, and drugs, so that we could plan a proper management strategy. What is the aim of the diagnosis? So essentially the aim of the diagnosis has been a systemic disease exclusion, be it diabetes, pituitary adenoma, testicular cancer, paternal genetic disorder exclusion in the form of cystic fibrosis, microdeletion, or a chromosomal karyotyping depending on the paternal age. Etiology, it is important to know the cause of male infertility so the specific treatment can be selected. Reversible conditions like hypogonadotropic hypogonadism, steroid misuse are addressed. Medical problems associated with treating erectile dysfunction or long-term testosterone replacement therapy. The aim of the diagnosis in a urology residency program, or when you are structurally not going through an andrology structured program. What is lacking is the understanding of gamete competence testing. Know that in the era of gamete competence, the functional integrity of spermatozoa is not evaluated, and majority of the treatment is based on dynamics of motion characteristics of the sperm to decide competency. In the era of advanced andrology diagnostic, urology should be empowered to understand using advanced tests to assess functional characteristics of the spermatozoa and tailor the treatment accordingly. Unlike oocyte, which has a reparative capacity and is not available for studies and is assessed by indirect means, sperm luckily for us is available. This is particularly important in the era of assisted fertilization as well as in men who desire natural conception with unexplained infertility. This allows us to estimate sperm potentially capable of fertilizing oocytes. If you look at the evolution of andrology diagnostics, we know this is the evolution where andrology has evolved from basic analysis of concentration, morphology, motility, pus cells, fructose, and all that, which is what most of the andrology specialists do, to ROS, oxidation reduction potential, DNA fragmentation, aneuploidy assessment, nuclear maturity test, mitochondrial function assessment. So there are various tests which are evolved. Why? Because of the fact that ultimately fertility is all about understanding a good competent sperm. So gamete competence due to systemic illness also gets impacted, and there are various conditions, especially today in the era of diabetes and hypertension, where impaired glucose affects male infertility, dyslipidemia affects male fertility, hypertension, metabolic syndrome, lifestyle, etc., paternal age, male fertility, and so consequently all these systemic diseases could have an impact on male fertility management and dynamics of gamete competence. And knowing the extent of the gamete competency or incompetency is very necessary for optimization of the treatment. And we know when there is a high prevalence of metabolic syndrome, especially being India or the South Asian subcontinent being the diabetic and the hypertensive and dyslipidemic capital of the world, we know that there is a significant impact of the metabolic syndrome on the sperm quality. So there is an evolution of andrology diagnostic pipeline, and we are looking at a past era where we do basic assays, hemizona, Manos, binding assay, lipid peroxidation, DNA fragmentation, oxidation reduction potential, hyperactivating, aneuploidy, to the next generation sequencing of proteomics, metabolics, genomics. there are gamete of tests which are available, which will empower the andrologist to manage his case better. In fact, we have been working on biomarker discovery by using integrated approaches where we have used RNA transcriptomics. The whole idea was to identify whether we could identify the presence of sperm using RNA transcriptomics, and we have been very successful in identifying 19 molecular markers, wherein we believe that with these 19 markers we can differentiate between obstructive and non-obstructive azoospermia with a single site biopsy collection with a small amount of tissue which is sufficient by a fine needle aspiration, and it has almost a 95% sensitivity and a 95.7% specificity for the presence of sperm. And this kit is launched in India, and it will be shortly be taken up by Cooper Surgical, extensive use, because this would avoid probably unnecessary surgeries, especially in the case of non-obstructive azoospermia. Similarly, we have been able to launch move away from the motility-based sperm assessment or sperm preparation techniques to hyaluronan magnetic bead-based sperm preparation techniques, which give 8 to 10% higher pregnancy rate. And this is all these are patented products both nationally and internationally. And this is launched by Bharat Serum in India, a first product developed in India, launched arena of sperm preparation, and it's, as you can see, it's called Spremio, and it was recently launched in the X-ray conference in Mumbai. So additionally, we also are looking at non-cryogenic transport, preservation of motility. One of the major challenges for sperm or semen has been that semen was not transportable, and consequently standardization between two labs, unlike blood samples, never happened. So you could report anything you want and claim that the motility had deteriorated. So non-cryogenic transport has taken off in a big way, and we have launched our own non-cryogenic transport buffer. We call it a buffer, which is called Zapneal, where you could do the test 36 hours after the semen has been collected by an ejaculate, and you could report accurately motility and morphology. And similarly, we have buffers for DNA and ROS test buffers. So what this does is it allows the sperm to move between area to area, and you are not confined to going to the lab and giving a sample in 45 minutes for 1 hour. Similarly, husband sperm and motility buffer. That means we can give an improvement buffer to the husband to do a self-insemination at home. So these are all technologies which are coming in. So what is the shift in andrology overall? So one is sperm competency and incompetency assessment, which is becoming extremely dynamic, and which is also very, very powerful tool. Sperm selection, sperm presence in tissue, remote diagnosis, identification of fetal transmission risk, standardization of lab testing and QC, and sperm transport similar to blood, home-based treatment or point-of-care solution. This is what has happened in the field of dynamics of andrology evolution. Similarly, when you look at male sexual dysfunction, this is a rather busy slide which essentially looks at urology's attitude to what is more important. Is there an association between ED and CVD? What is the most important clinical significance of relationship between ED and CVD? How to assess the risk of CVD in patients with ED? And what is the urologist's attitude to treat ED? And so this is a survey which was an extensive survey between andrologists and non-andrologists' attitude on various aspects of it. I'm going to summarize the findings. So when you look at urologists' present training in sexual medicine, which is another component of andrology, urologists' approach to treatment of ED in patients was insufficient in their diagnosis of ED itself. Most of them only considered conventional treatments such as psychological intervention and PD5 therapy for their patient. In fact, most other treatments are also effective for ED. We know that testosterone therapy is beneficial for treating MSD, especially in men who are unresponsive to PD5. And we also know that serum testosterone represented an increased risk for CVTs, especially if it is low. Most urologists actually know about the risk of CVD in patients with ED, but their assessment of CVDs in patients with ED was disappointing in the clinic. Consequently, what has happened is we just use an undifferentiated prescription. Anybody walks in, primary undifferentiated prescription, that means we don't need a diagnosis. We have an IAF scale score, or you don't even use an IAF scale, you use a SHIM score, grade the erection, put him on a PDE5 inhibitor without assessing whether there is a significant vascular risk or not. Because finally we have to understand that the world is moving to an era of identification of endothelial dysfunction. We know most of the cases nowadays we see in ED because of the various comorbidities of metabolic syndrome is because of endothelial dysfunction. There is a very poor understanding of endothelial dysfunction, and the research has progressed in identifying several cellular markers which are potential markers of vascular dysfunction and coronary artery disease in the form of monocyte counts, asymmetric dimethylarginine, symmetric dimethylarginine. There is also extensive research on the biomarkers in the form of acute phase proteins, cytokines, cell adhesion molecules, which are all extensively studied as endothelial dysfunction and inflammation markers. And we also have non-invasive tools to identify normal endothelial function and abnormal endothelial function without going through a stress test or an angiogram, as was the case many years ago. So you have a male who has several risk factors now in the form of metabolic syndrome, hypertension, obesity, lifestyle, sedentary, and you have a gamut of technologies which are available for assessment of the vascular risk. And we as urologists are presented with a golden opportunity, because the first artery, which is narrower than the coronary artery, is the cavernosal artery, and consequently a dysfunction in the cavernosal artery may be a sentinel marker of a cardiac assessment. And these are validated tools, as you can see, which are non-invasive, repeatable, reproducible, and reflex biology, reversible, and to a large extent predicts outcome. So these tools need to be incorporated in the routine practice of an andrologist to be efficiently deliver the service which is non-undifferentiated prescription based. Why is it important? Because pharmacological strategies to prevent endothelial dysfunction is evolving, because we are looking at targeted treatment in the form of glucose lowering agents, statins, anti-inflammatory drugs. You have tocilizumab, janukinase inhibitors, zafirlukas, vorapaxar, tigaglicor. So many drugs are being researched in the area of endothelial dysfunction. The aim of any male is to regenerate his endothelium, have his erectile function restored to as near normalcy as possible. I don't think any male would want to be taking a PDE5 inhibitor, and PDE5 inhibitor is not the answer, because as the disease progresses, the same PDE5 inhibitor may be ineffective. And we are also looking at non-pharmacological mechanisms of inducing angiogenesis. We are all aware of the utility and use of shockwave therapy. Still, it's a process of evolution where the shockwave therapy, where it is to be given, who is the best candidate, ideal candidate, is still being debated, but it does help in a specific group of individuals if you give it after proper assessment. Similarly, you have modification of the endothelium strategy, or regenerating the endothelium strategy, either with using the platelet-rich growth factors or with your stem cell therapy, be it bone marrow stem cell, umbilical cord derived stem cell, adipose derived stem cell. So you have several armamentarium which is available for you to manage your sexual dysfunction patient in totality. So to summarize, the ED management is all about personalized strategies, because we know ED is a complex neuronal, vascular, molecular interaction with intact anatomical and mechanical structures supplying arteries and elastic sinusoids, which can be impaired at various points and lead to the development of erectile dysfunction. Complex Complexity and difficulty of the problem should not lead to use of drug therapy as the universal approach. On the contrary, if we are unable to identify a respective component of erectile dysfunction in an individual case due to lack of diagnostic possibility, a strategy for identification of optimal therapy must be developed. So the future is all about defining a precise erectile dysfunction time. Is it neuronal, vascular, central, peripheral, visual, tactile? Understand the molecular physiology and having a specific diagnostic and a targeted therapeutic approach. Erectile dysfunction in a vast majority of affected men presently is typically treated with one non-cause specific treatment, which is a primitive approach, which is an undifferentiated prescription, which must change. Now, finally, andrology also is moving to the area of men's health domain. Now, what is men's health? Urologist's role in this is highly confusing for many. How does the urologist take the lead? What are the tests? What are the outcome measures? How to implement in a solo practice? Are you going to have a gamut of diseases and specific events which you are going to monitor? How are you going to monitor? Do you have the competency? If you look at what are the andrology service lines, you be it male infertility, erectile dysfunction, men's health, it is a gamut of technologies which have evolved. You have advanced diagnostic andrology, surgical andrology. We have even gone into automation of reports, regenerative andrology, cryobranching, preventive, vascular disease diagnosis lab, regenerative therapy, endothelial assessment, comorbidity management, stem cell therapy, and similarly for men's health, where you're looking at vascular risk prediction, vascular risk assessment, mental health risk prevention package. So there are several things. So the consequent, what is andrology all about? Focused on total men's health solution. That is what is andrology all about. So the expansion of andrology is encompassing medical and surgical components. The shift from empirical to directed treatment. Key understanding is there is no one fit all. Surgery is a small part of andrology management, and surgery is needed probably in less than 20% of patients. Even this will shrink further. So, present situation in andrology training, the management of andrology problems may require medical management or surgical management. Differences in background training makes andrologists, so-called andrologists, manage surgical andrology conditions and refer cases requiring medical management to others or vice versa. Not all andrologists are urologists. Not all urologists are properly trained andrologists. Several subspecialties trained in internal medicine, endocrinology, RM are taking up management as medical andrologists. So we all know the challenges in USA and Europe of still andrological evolution in terms of, but they have much better structured program than us. What is further unique challenges to andrology? RM evolved much faster due to IRT technology, which integrated very well with embryology. And ART technology evolution made sperm irrelevant for many decades, and research was suppressed. Research in andrology evolved significantly over the last decade as sperm again took center stage due to risk of miscarriages and optimizing pregnancy. Diagnostic laboratory andrology is fundamental to optimizing pregnancy rate. Similarly, sexual dysfunction and endothelial assessment lab. Laboratory andrology is the branch of andrology in which all laboratory diagnostics of male reproductive system are performed, and reports should be validated by an andrologist. Andrologist plays a key role if he is able to assist RM in achieving optimal pregnancy and not just treat based on surgical choice, and look at couple holistically. Tendency to segregate as clinical andrologist, laboratory or medical andrologist is irrelevant, because who is a medical andrologist? Are we going to allow lateral entry into the field of andrology of people who are not supposed to be in andrology? Unless andrology is a director of the whole andrology service, outcomes will be poor. Further evolution is happening in andrology. There is a current trend to develop men's health clinics to handle male problems, including andrology. As men's health clinic develop, there is a need for andrologists. But are we going to restrict only to surgery even in this? Is monetization the challenge to handle comprehensively, or our surgical egos? Because we are surgeons. Are all we surgical andrologists when the surgical problems in andrology is 20%? Who manages the rest 80%? The training should begin, according to me, on comprehensive management strategies akin to reproductive medicine, covering all aspects of patient management, both clinical, laboratory, and research. In all urology meetings, I have seen the main focus is surgical management. Who will cover the gaps? And how will urologists be trained? You see, any reproductive medicine meeting, they cover encompass subjects which are wide, varied, beyond, and it is comprehensive dialogue. We lack that. Others are biting the pie, ready to take the lead. We don't take the lead. We have gynecologists, endocrinologists, dermatologists, internal medicine who are just waiting to take up the lead in andrology. Way back 130 years ago, I was surprised to get this article, in 1891, where the section of andrology was approved in the Congress of American Physicians and Surgeons. And that is a landmark. So andrology has existed for 130 years, just like our patients. In the end, whether male and female reproductive training remains separated or begins to merge may be of limited consequence. It is the quality of training, assurance, and maintenance of competency and willingness of the physicians to work or the surgeon to work with the couple and other subspecialties that will determine the quality of care. The exigencies of practice and patients will finally determine the subspecialty development, either by us, urologists, or other specialties will take the lead. Or andrology will be torn apart by different specialties to suit their need. Medical andrologists, surgical andrologists, laboratory andrologists. As with many challenges, there are many ways to skin a cat, but I am an eternal optimist. To summarize, are there new horizons in andrology? Extensive. Andrology is going to explode in the next decade. Are we heading towards super specialization? I think it's an irrelevant question. It existed 130 years ago, it still continues to exist. It's time urologists and societies look beyond surgery and develop and impart skill sets for comprehensive management before it's too late. The subspecialty existed from 130 years and is here to stay. Question is whether it will be led by urologists or others will take the pie.
Loved by mankind.